Good afternoon and welcome to today's Melbourne Institute Colloquium. My name is Roger Wilkins and I'm the Deputy Director of the Melbourne Institute. Before we begin, I'd first like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. These colloquia replace our normal face-to-face forums and workshops. Our goal is to provide insights of Melbourne Institute researchers and to also engage with you, the audience, so we can better understand Australian economic and social policy issues. Today we have Professor Yuting Zhang discussing the design of the Australian private health insurance market, looking at the factors impacting on consumer choice and the policy changes in this space. Yuting is a Professor of Health Economics at the Melbourne Institute. She holds a PhD in Health Policy with an economics concentration from Harvard University, and also a Master's in Health Policy and Management from Harvard University as well. Her research areas include economic evaluations of international health policies, pharmaceutical policy, value-based healthcare design, health insurance markets, and health system reforms. She is a leading scholar in using advanced quantitative methods and novel combinations of big data to study policy impacts and individual choices. So Yuting will speak for approximately 25 minutes, following which we'll have around 15 minutes for questions from the audience. A note about how we're handling questions and comments. For those of you watching through Zoom, we're relying on the Q&A function found at the bottom of your screen. For those of you watching through Slido, you can submit questions in the box at the right-hand side of your screen. You can submit questions at any time through these functions, and then I'll relay those to our speaker, Yuting, during the Q&A session. So with that, I'll now hand over to Yuting.
Thank you, Roger. Hi, everyone. Thanks for being here. Let me just share my screen. So today we're going to talk about private health insurance. I'm sure it's a topic everyone's sort of quite familiar with, but let me start with, let's think about the insurance theory 101 sort of. When we make individual choices, we often involve uncertainty. For example, we don't know, when we talk about health insurance, we don't know the timing we need the healthcare and how much it might cost and the likelihood we need that. And because in general, we don't like risk, so we're willing to pay a bit to avoid that risk. And by pooling all the risks together through an insurer, that can help us mitigate some of that risk. But when you think about pooling arrangement, it doesn't really mean the premium you pay is what you end up getting. Like the medical benefit is probably for a particular person would be either higher or lower than the premium that person pay. But when we talk about large scale, that can hopefully the total premium generated will be more than enough to cover the total medical cost. So when we talk about premium, I'll just explain a little bit about premium. Normally, it includes two parts. So when we talk about actuary fair value, so that's sort of the expected medical benefit in the health insurance context. And then the other part is loading fee. Sometimes we call that price of insurance. So that might include administrative costs, a profit insurers can make, taxes. So when you think about value of insurance to you, so apparently that will be one part is the actuary fair value, which is the expected medical benefit. But also because we in general don't like risk, so we're willing to pay a bit more to avoid that. So part of that value from insurance is also included in the loading fee. But in general, when you think about, you might hear a term, it's called medical benefit ratio. So basically it's the total medical expenses paid by insurer divided by the total premium the insurer collected. So it'll be this, the first proportion divided by premium. So apparently, as you can see, you wanted to look for insurer which with higher medical benefit ratio, because you end up sort of getting more for the money you paid. Some countries, they have a pretty high regulation in terms of medical benefit ratio. For example, in the US, the minimal medical benefit ratio is 80% for a smaller sort of insurer, but for the larger one, it should be 85%. And in Australia, it varies a lot. It can vary from 60% or 90%. So you have to look into which insurers sort of give you the higher medical benefit ratio. So premium is one factor when you think about how you choose health insurance. And you also need to think about the out-of-pocket spending at the time of receiving the treatment. So that can be in the form of deductible or co-insurance, which means proportion of the total medical costs you pay out of your own pocket at the time receiving that treatment. But also you think about what's the likelihood for you to have an illness that you really need a healthcare. And then general, like your magnitude of loss relative to income. So say, if you expect to have medical costs for like $500 in a year, but you're super rich and $500 relative to income is very small proportion. So you might not willing to buy insurance. But also in general, your degree of risk aversion. Like some people, they're willing to pay more to avoid risk, but some other people, they might risk seeking. They don't want to pay a lot more to avoid risk. And the other factor would be your income. So think about insurance as sort of normal good. The richer you are, you probably want to purchase more. So that's your income, pure income effect. And then the other one is government policies. And that's really sort of important in the health insurance space because it's highly regulated, not only in Australia, but pretty much in most of countries. So you need to understand what different policies and then make your decision based on that. So this figure, I'll show you the current proportion of Australians having private health insurance, and it's by age group, so over time. So the sort of this line here, it shows you on average overall Australian population. So you can see initially in 2008 it's 45%, and then over time, relatively stable, except recently it has declined a bit, but not that much if you look at the numbers. And then you look at by different age group. The ones going upward trend, those are older population. This one, for example, is those for age 70 to 74, and then 75 to 79. And then those dashed line here is for relatively younger cohort. So we have here, it's the 20 to 24, and the lowest is 25 to 29. So you can see the trend recently in the last 5 years, it has declined quite a lot among the young population. So one reason for the young, they drop out from their insurance is because the value to them relative to the cost it's pretty low. This chart shows you sort of like give you some numbers, help you figure out what's going on here. So basically, this is the bar represents the difference between expected hospital benefit and the annual premium. So say, for example, I assume I use sort of like a moderate median premium for moderate plan for individual. So roughly $200 per month. And I give you annual premium $2,400 per year. And for example, for those 20 to 24, the first bar here, the expected benefit that person might get from that year per year is 550. I just sort of on average for that age group, they probably use that much and then they get paid for that much in terms of covering their medical care. And 550 minus 2,400, so that gives you sort of a negative number here. And that's this bar shows you for different age groups. So you can see for the youngs, their expected hospital benefit is a lot less than the premium they're paying. For the older ones, it's the opposite. So apparently older population, they're more likely to buy it. Oh, one thing I should mention here, it's a community rating premium. That means the premium is same regardless who you are. Doesn't vary by age, doesn't vary by your health condition. Okay, so I'm gonna pause here. I'll just ask a question like, who among the audience, who do you currently have private insurance, health insurance to cover your hospital treatment? So we're focused on hospital treatment here because most of the government policy only focus on hospital cover. And then if you do, what the reason why you're buying it, if you don't, and the reasons you don't have it. And then I'll show you your results as well as what we see from the national survey. So I'll give you a minute. You can choose multiple choice for the reasons. So as some of you know, at the Melbourne Institute, we conducted taking the pulse of nation survey since March 2020, just to looking at economic and social well-being of Australians during the pandemic. So some of the questions are related to health related. So we asked them about the healthcare they're seeking and if they drop or downgrade their, oh, here's the results. So, okay, among this audience here, 65% of us having private hospital insurance to cover hospital treatment. That's a lot higher than national average I just showed you. And the reasons not having it, a lot of you don't know why.
Yeah, Yuting, I just have a comment there. The way the question was set up, you couldn't submit without giving an answer to both questions 2 and 3. So that so people might have put don't know. Just to allow them to submit.
Okay, that's all right. So I guess, okay, premium too expensive, happy with public hospital. And if yes, the reason is I'm better off, that's really high. A lot of you doing it because of sort of like government, related to government policy, which I'll talk a bit more later. That's really interesting. Thanks everyone for participating now. So as I was mentioning, we did the taking the pulse of the nation survey, right? And then we asked them recently in April, May, the same question you just answered. And here's the results showing you the reasons for not having private health insurance. One of the most common reason people gave is premiums too expensive or out-of-pocket spending is too high. So I demonstrate here, and different colors represent different sort of population group. Like this is entire overall population, young, old, employed, unemployed, financially distressed, stressed, or financially comfortable. And then it's really interesting here is people think about they're happy with the public hospital system. They're happy to use public hospital. This is interesting because this number has gone up quite a lot since like 5 years ago, which was the last time National Health Survey asked the country this question. That was only 29% of people saying they're happy with public hospital. So over time, more people think they're happy to use it. And then about 20% of people think they're healthy, they don't need it. If we look at reasons for having private insurance, okay, so this one, the main reason really interesting, one of the most common one is security, protection, peace of mind. This is quite interesting. Even in Australia, everyone has Medicare that covers pretty much free care in public hospital. If you think about insurance, it's really protect your catastrophic expenditure. We are essentially all covered in Australia just through Medicare. So I find it's surprisingly high, this proportion. And then this one, another common reason is they want to take the benefit of private treatment, which is unsurprisingly, right? Because that's the whole point of having private insurance. You just having shorter waiting time and more choice of doctors. And then I'm better off financially. About 30% of people think that's the main reason. And this number is slightly lower than what you guys just showed me. And then another one, 26% of people think they need it for the current health condition. This is sort of one of the things in insurance we're worried about is adverse selection because people know their health status better than the insurer. So when they need it, they're anticipating needing it. They starting to buy it. So you end up having to pay a lot of medical benefit. But this number basically suggests we don't have a very severe like adverse selection in the Australian private health insurance market. So when we talk about you are better off financially, mainly we think about like three main government interventions in Australian private health insurance market. One of them is Medicare levy surcharge. Most of you might have heard about that. So basically it means for people who earn above a threshold, income threshold, they have to pay extra tax. So here I give you the single income, but for family, you just multiply by 2. So if you are single in this income threshold, you pay 1% extra on top of the Medicare tax everyone pays. So this is called Medicare levy surcharge. So it's on top of that. And then if you're in this threshold, you pay 1.5% and then 1.5%. This policy was first implemented in 1997, so very like it has been there for a while. It had some changes in 2008 and then also 2012, mainly sort of increasing the threshold a bit and also make that more indexed to the wage. So the second main policy is rebates. You probably heard that has been debated a lot in the political elections on that. So also was first implemented in 1999. Initially, it was 30% throughout, regardless who you are, your income, your age. But now currently, it's means tested by income and also varies a bit by age. So if you're older, then you have the highest rebates. And if you have lower income. So the last one is a lifetime health cover. I'll talk a bit more what it is, but basically if you don't buy it when you turn 31, you pay 2% of loading each year for up to 10 years. So I wrote an article recently on the conversation, basically just talk about all this policy, government policy impact, what potential impact on your individual choice, private health insurance. The bottom line is, even you don't expect to use any of the private hospital, just if your goal is to save money, but your goal might not be. If you're above a certain income level, then you should buy it just to save money, basically, because of that government policy. And then we also did a research insight, just using the most recent, taking the Pulse of Nations survey, sort of give you a big example. This is an individual by income. The bars are premium you would have to pay if you buy a basic cover, private hospital cover. And this line is the potential Medicare levy surcharge you pay, depending on your income. So above this income, you would potentially save money if you just buy the basic cover. But interestingly, in our data, we have about 30% of singles above this income level. They did not buy private hospital insurance. And the reason they're not buying it is sort of similar as the reason I just showed you. 76% of them think premium is too expensive, out-of-pocket spending too expensive. 57% of them think they're happy with public hospital. But apparently this has some limitation because our sample is quite small, and the way we sort of did not directly asking them about the Medicare levy surcharge, we just asked the same question you just answered earlier on. But it does bear a question that does this Medicare levy surcharge is still effective, especially if people buying it, but they're not using it. It doesn't really reduce the pressure of the public system. Do we have sort of a better policy that we can potentially think about? So one of the calculation I just presented early, we didn't really think about lifetime health cover. You might hear anecdotally, or even yourself, you're probably starting buying private health insurance when you turn 31, just because of this lifetime health cover. But let's think about it. Is it really, how much does this really affect people's decision? If you think about what it means is without hospital cover, so the baseline is always July 1st. Before July 1st, following you turn 31, you pay 2% loading on hospital premium, on hospital part of premium for each year. And then next year you pay, like say, next year is 4%. So it add up to 70%. And then the loading stops after 10 years of continuous cover. So the maximum penalty of the loading is 10 years. Let me give you some number, just help you run through what this policy is really about. So if you buy it when you're 30, you don't have any loading, right? And then the loading starts 31, 2% initially. You pay for 10 years. And that's like, again, here I assume like $200 premium per month. So 2% of that for 10 years, that's only $480. But say the total premium you could potentially save by not buying that is $2,400. And say if someone started to buy at 32, then the loading would be 4%, right? So you keep adding up each year by 2%. And that's the penalty for 10 years. And that's a potential premium paid. You have to pay extra premium if you start at 30, right? But if you started paying at 32, you potentially save that much money because you pay 2 years later. Does that make sense? So basically, and then this loading goes up to 70. So that's around 65. If you wait until 66, you buy it, it's still 70, but everyone just pay up to 10 years. So if you look at this number, think about this policy. It's supposed to affect everyone each year because each year you have to make same decision, right? Each year the loading increase by 2%. I'm thinking if I'm 31 now, I definitely don't need it. I'm not going to buy it just because 2% loading. But next year, I have to make this decision again because next year I might say, oh, I would need it because I anticipate I'm going to use private hospital for, like, say, giving a birth or something. And then why don't I start buying it a bit early just to avoid when I turn 33, the loading would be higher. So each year, technically, you should make this type of decision if you're really rational thinking, right? So it's not just affecting when you turn 31. So here's one of the currently working paper we're working on. This is with joint work with Nathan Cattlewell from UTS. So for this work, we're looking at the impact of lifetime health cover on private health insurance coverage using the admin data from Australian Tax Office from 1999 up to 2017. So we're trying to design it in a way sort of as a causal analysis by using that each year people before they turn, like each year before July 1st, remember that's the base, sort of the base day every year you making decision before and after that day. And then by each age, like say 31, 32, up to 65 when your pension starts. So here's what we see. So this one shows you in 2017, sort of I told you in theory that policies should change each year, then you should see sort of a jump around just you turn that age on July 1st, right? But we don't really see that for all the ages except for 31. So basically saying people only respond to this policy when they turn 31, but they're not really responding to it for any other age. And this is just keep plotting for age 40 to 50. If you keep going up to 65, it's pretty much same. There's no like a jump around that starting point. And then how much is that? How much is that effect? This figure shows you focus on, we zoom in for age 31 because that's the only age group somehow affected by this policy. And then we're looking at over time. So this policy started in 2000. So the first year after that, it has the highest impact. This one shows you the lifetime health cover policy increase the private insurance coverage by like about almost like 4 percentage points. So that's roughly like a 10% increase given the mean level of that proportion of people having insurance back then in that year. And then this impact declined over time, reached its low point around 2006, and then went up again, starting in 2008, and roughly stable there until recently, and that's roughly about 3.5 percentage point and roughly about 6.6% of the impact. So initially we were thinking, because of a lot of young people, they started dropping from the private health insurance. So one of the motivation for this work is maybe this lifetime health cover policy is not as effective now, but that's not what we find. So it has been sort of effective except around this period of time. And then the next question is, so we saw lifetime health cover does increase private health insurance coverage, but only just on the margin for people just turned 31. But then the next question is, do people having more insurance, their use of private hospital, does that change? So this is another ongoing work with my colleagues at Melbourne Institute, Maxime and John Say. This is using completely different data set. So this one, we use Victorian hospital data from 1998 up to 2004. So the design here is, okay, we have this comparison group, it's age 30, right? They're not affected by this lifetime health cover. And then we have another group, ages turned 31, they're affected by policy. We look at before policy implemented, we look at post policy implemented, and the outcome is private hospital admission. So we do see increase in terms of admission to private hospital instead of public hospital. This is, we look at like 12 million hospitalizations during that period of time. And the magnitude is about 1.8 to 2 percentage point in terms of proportion of choosing private hospital, conditional on someone need to hospitalization. So I don't know how much time we have, but this is last slide basically. Basically, this is a very sort of interesting topic, and it's touches everyone's life. I recently got a ARC Future Fellowship, just started last month, looking at this topic. So the main aims from this fellowship is looking at apparently what the factors affecting individual choice in their health private insurance, and then the impact of having private health insurance on healthcare use and choice of hospital care, and also quality and waiting time of the hospitals, and the impact of government policy on individual behaviors. And I showed you a bit on the lifetime health cover today. We also have some other planning or ongoing work looking at how people respond to rebates and the Medicare levy surcharge. But fundamentally, if you think about all these things, the current government intervention mainly focus on the aim is to increase the uptake rate of private health insurance. So encourage people to enroll in private health insurance or enroll early, but encourage the young people to be in there. But we should ask the question is that what's the role of private health insurance in the overall sort of Australian healthcare system? Should government is increasing the coverage the only goal the government policy should be playing in there? And what are the private insurance sort of role in this whole thing? The currently private insurance, they're quite regulated. They're not allowed to do a lot of sort of innovative insurance design to improve population health. So we want, part of this whole work is trying to think about how do we design insurance to improve the overall healthcare system efficiency and ultimately improve Australians' population health. So we're going to use lots of really large existing admin data, like tax data I showed you, like Victoria linked data I sort of mentioned a bit, but we have a lot of most recent ones, also linking with other social human services data. And the other one is national sort of linkage data, is called MAGDIP, and link with census, income, government payment, and some of the healthcare data. So apparently what I can show you today is quite limited, but stay tuned. We have a lot of more interesting work coming up. And if you have any questions and ideas, feel free to contact me. I'll be always happy to discuss. So I'll stop there. Let me stop sharing.
Great. Thanks, Yujing. So now we have time for questions, addressing questions from the audience. So I'll just remind you that we're using the Q&A function in Zoom and the box to the right of the screen in Slido. So feel free to put your questions in there. I guess, you know, this is yeah, it's almost a question of where to start. There just seems to be so many policy issues in play in this space. But you know, you did raise the question of, well, what is the goal? What is the goal when it comes to private health insurance? You know, why is it? You know, does government rationale extend beyond just that we want to maximise the number of people with private health insurance? So, you know,
the justification is more like more people enroll in private insurance, and they use more private treatment in private hospital, and that can relieve the pressure of the public system. So potentially could reduce waiting time and other things. But there are really not a lot of evidence supporting that. One of the current paper we're working on, just looking at the impact of private insurance on waiting time.
And so what to you do you think makes sense as a policy goal here? I mean, I think, you know, if you're going to have good policy settings, I think you need to firstly have a good
Right.
appropriate goal, right, that you're heading towards. And
yeah, I was thinking it would be the overall healthcare system, regardless it's private, public, but you definitely have to think about it in a bundled way. And then apparently improving health while we use the least amount of resources while saving cost. People often say that. So that's probably the ultimate goal.
Right, yeah. So, I mean, at the moment, it looks like the mix is, there's sort of there's some effort at subsidizing and using carrots for sort of, I guess, lower income people, but also there's also sort of an age angle, and that there's more emphasis on carrots for older age groups.
Mm-hmm.
But then as you sort of become more higher income or younger, so lower risk, they state that there's more of an emphasis on sticks, so surcharges and and premium increases and so forth. I mean, is that a sensible approach?
I sort of think it's a bit unfair for the young, but so I think because we have this community rating, so the whole point is you have to have enough young people to be there. Otherwise, the premium just keep going up and it's just going to collapse. But is it really fair to punish the young people just to make sure they stay in there? Should we just give them a bit more incentive, or should we just design it in a way make them more valuable to the young to buy it? Like, say, providing more services they actually need, things like that. I think the current policy reform is trying to get into that direction.
So what about age-related premiums? Would allowing insurers to charge differential premiums based on your age be a sensible?
I would think so, but I understand the political thing. It might be quite different environment here. I think in the US, the marketplace, individual marketplace insurance market, the premium does vary by age, can be up to 5 times higher for the older population than the young. UK does something like similar like that, but Australia, I probably would not be surprised. It's quite hard to push forward.
I mean, could you pair it with something like a subsidy that was also age related, so that?
Yeah. Some talks about the rebate should be higher for the young. At least going back to the initial period when just started rebate, it's 30% throughout for all the age group. But now the currently older is higher rebates and the younger lower rebates. But essentially, because if you look at the price elasticity, it's quite low. So by increasing a lot of rebates doesn't really give you a lot of outcome. So as a government, you might use that money somewhere else more efficiently.
Yeah. So someone has mentioned that the recent policy changes have been aimed at simplifying consumer policy selection, in balancing their lifetime risk. So they've talked about these gold, silver, and bronze categories. Do you have any? Have you done any analysis, or do you have any metrics on?
Yeah, there are a fair amount of analysis. Basically, if you have a lot of choices, it makes people very hard to decide. Not in Australian context, but in the US, we know, like, initially the Medicare Part D started. There were like 30 choices to choose from. People got very puzzled. They can't do any decision. So the new reform in the Obamacare is just go to the full metal level, and that's what Australian currently doing. It's for just very simple, like a basic silver, bronze, gold. That's definitely better in terms of fuel choice, make people much easier to choose from.
Right, and I mean, well, I guess a related sort of question, but I'm not quite sure where they're going. But they talk about is there any consideration around removing high-cost items such as obstetrics from private health insurance products? But my understanding is that there are insurance products where you can choose not to have that coverage, right? But there's other areas.
That's right. Yeah, you can choose some basic ones cover very little services. Some like most premium one, like very generous one, but you have to pay very, very high premium for those.
And someone has commented that we do have age-based discounts for those under 25. I think that was
Yeah. It was like 2% up to 10%. One of my figures I showed you, that orange little bar that's represent the age-based discount, but you can see it's very tiny. It doesn't make any difference.
No.
You look at the number, the current, the reform was started 2019, but it hasn't resolved. It haven't resolved anything.
And we saw that the 25 to 29-year-olds were the ones who actually had the lowest coverage, and it was still, there's still plenty of room for an age gradient and premiums above age 25, right? So.
Yeah, and that's because up to 24 they can be treated as dependent as their parents one. So you might see a bit higher for below 24, but.
Well, someone has asked a question about, I guess, private health. They're still talking about private health insurance, but I guess what they're called outside the acute setting. So I don't know whether they're talking about extras or whether they're talking about chronic conditions. I'm not sure exactly what that question is about, whether the that person
so
clarify.
Yeah. Acute, well, for chronic condition, if you use hospital, it will be same hospital cover, but also there are extra care that would normally be like dental, optical, physical, physiotherapy, those things. Yeah, those government policy we mentioned here doesn't really apply to them, except a little bit rebates on some of that, but other ones don't.
Sure. Now, look, we are running out of time, and I'm conscious that there's been a number of questions here that I haven't posed to you, Ting, because I'm not. I'm having a bit of trouble interpreting some of them. We will be posting a recording of this colloquium online, and we will endeavour to answer, or Yiting will endeavour to answer the questions that I haven't put to her today. So look out for that recording and those responses online. So we do have to wrap up there. So thank you, Yiting, and thank you for the audience for your participation. I hope you've enjoyed this colloquium, and I look forward to seeing you at our next one on the 21st of September, when Dr. Viet Nguyen will be presenting on the topic of capturing heterogeneity in consumer sentiment. So you can register for this colloquium by following the link that should have just been posted in the chat function in Zoom and posted next to the live stream in Slido. But until that next colloquium, thank you again, and goodbye.
Thank you. Bye.